Welcome to Current Management of Chronic Myeloid Leukemia. This is medical oncologist Dr. Neil Love. For this roundtable style program, I was joined by faculty members Dr. Jorge Cortes, Michael Mauro, and Neil Shah, and by Drs. Tina Bhatnagar and Amanda Blackmon to present cases to the faculty. To begin, I asked the investigators about their thoughts on the data of ASK4FIRST, a pivotal phase 3 trial of frontline asciminib that was recently presented at the ASCO 2024 meeting.
I think it was very remarkable. Honestly, I thought that's kind of what I would have expected, knowing that the asciminib's potential in third line and T359 and all of that. That was the intention to try to get to better results in the front line. Clearly, what we're seeing is the early responses. There's a lot to be seen in the long term, and we want to focus on that. But I was very satisfied with the efficacy and the safety that was seen on these early data to suggest that it is a step forward, and I think it's good to have an additional option for patients if this gets to be approved.
Neil, I'm just kind of curious. You know, we know a lot of our audience has only been in oncology 5 or 10 years. We have a lot of fellows, so a lot of people aren't familiar, kind of didn't live through the CML story. When again thinking about this presentation, this data in light of what had preceded, any thoughts that you had as you saw it presented?
Yeah, well, I think, I certainly expected it to be better than imatinib, right? We know the second generation drugs are better than imatinib. I expected it to be very tolerable just based on, my clinical experience in the third line setting. And, I think it is. I think there are some unanswered questions, related to cardiovascular issues, which, with 1 year of follow-up, we're not seeing much, which is great. But, I don't think... unless a drug really has a strong signal like ponatinib, I don't think we're going to see a lot after only 1 year. I think maybe after 3 years or after 5 years, we'll get a better sense of that. It's, the fact that it was, I guess, numerically better than the second generation drugs, is intriguing. It's not enough to say that it's, from a statistical significance standpoint, superior, but at least it looks no worse. So, I will echo what Jorge said in that, I think it's fantastic to have, more options, especially, if we think that most patients, the majority of patients are going to need long-term therapy, tolerability on a day-to-day basis is a really important thing for patients. So, I was definitely pleased to see that the data, look largely as expected.
Michael, anything you want to add to that? And again, to me, it seemed like really, of course, we've been following this story for a while, but seeing that data presented to me seemed like a real landmark, but you tell me.
No, I agree as well. I think it's important to remember it's building on a very long and very extensive phase 1 trial and a phase 3 trial in later line. So, I was hoping, as everyone else was, that we'd see superiority in certain elements. I think the trial design was very good. I think it's very defendable. When you're asking how could you prove a drug was a better potential choice in the front line, Neil's comment about the numerical difference versus statistical difference compared to imatinib in the front line is important. I would point people who have questions about tolerability to the long-term follow-up from the phase 1 study. In pretty heavily pretreated patients, people that had other TKIs, I don't think we would see less toxicity in that population. We might even see more because those patients had other drug exposures. And I think it's quite encouraging that the safety there were no new issues. And asciminib brings really a big step forward with a safe alternative in multiple settings for me in the clinic. And I think probably a preferred advantage in the front line. I get it that we could have a pretty robust debate about how we should be using it, but I think I expect it to be approved, and I'm going to be a big fan.
Yeah, we should have a little bit of that debate. Tina, any thoughts and any questions you'd like to hear the other faculty discuss about the study?
No, I mean, I've used asciminib in the third line setting and beyond, and I've been impressed by the way my patients have handled it compared to the toxicities they experienced on other TKIs. So I remember waiting for asciminib to be approved even in that setting. And so it's very cool to see it move further up the food chain. Yeah, I mean, I definitely think that there are some questions in terms of whether or not this is going to become our standard of care in frontline CML management, and how are you going to manage those patients who ultimately experience toxicities on asciminib, or if they develop resistance mutations like the T315I mutation. And, asciminib is unable to abrogate it. So I think, for me as a practicing oncologist, I'm not sure that I would adopt it in the frontline setting yet, but I did think that the frontline data looked really promising. I would just need to see longer term follow-up.
Amanda, any thoughts or questions?
So my question would be, when are we going to actually start using this frontline? I've had some colleagues try to get it, and insurance has been an issue. Has anyone successfully used this frontline at this time?
Yeah, so it's not yet FDA approved. I think, the expectation is it may be within the next month or two. At that point, of course, I think hopefully insurance companies will agree to pay for something that's FDA approved. But as we know, sometimes, even though it's approved in the third line, sometimes I get pushed back about, using it in the third line because the patient hasn't tried one specific TKI that the insurance company wants them to take before trying asciminib.
Michael, sort of putting aside access and regulatory issues, just looking at risk benefit right now, what are the situations where you'd like to use asciminib first line?
I have to admit that since I've been able to use it for almost a decade now, I'm feeling pretty comfortable. So, and I think about, highest reward, lowest risk. I really think it might meet that benchmark in frontline. So I'd like to use it pretty broadly in frontline. What would make the seal the deal for me would be if we started to see treatment-free remission eligibility and success improve. I think that's an important follow-up. So, I'm going to be diplomatic in my statements about how much we should be using in the frontline for now until we see how that pans out. But I'm probably going to be one of the most exuberant, users in the frontline because I feel very comfortable with it over a very long experience. I can bank off that for safety and tolerability.
Yeah, we know that everyone understands you have to individualize treatment decisions, but, oncologists want to know really, again, putting aside the regulatory issues, how you view, the pure benefit in terms of risk and benefit. Jorge, if cost and, access wasn't an issue, what situations, if any, would you want to use asciminib first line?
Well, the first thing I think when somebody asks me something like that is, what would I take if I had CML? Well, I would take asciminib. I don't know how big the difference is going to be versus second-generation TKIs in the long term, and particularly what Mike mentioned. Our main interest right now is TFR eligibility and success. Survival is not the point anymore. We've reached probably the ceiling of survival. But if I want to reach the TFR eligibility, that's what I want. Now we've kind of said, well, for patients who are not as focused on TFR, you probably can go with imatinib, mostly because of concerns about safety, arterial-occlusive events with nilotinib, probably some with dasatinib, the pleural effusions, these things. But because of the low risk of safety issues, particularly arterial-occlusive events, and as Mike said, we've been using the drug for 10 years in the phase 1. I think that anybody could be a good candidate for asciminib. Now, let's remember, the other drugs are good, and imatinib is a good drug, and imatinib is generic. So if somebody cannot access asciminib, I'm not giving them anything bad by treating them with imatinib. I'm okay treating them with imatinib. So the good thing is that we have good options for anybody, but I would prefer asciminib.
Yeah, just kind of curious about, as I mentioned, we do stuff throughout oncology. CML is the model for targeted therapy. But, once you get outside of CML, it's hard to see an instance where it's successful in the kind of model that's evolved. For example, EGFR mutant or ALK mutant non-small cell lung cancer, third generation TKIs, et cetera. They're still recurring. They're still dying. Any thoughts about from a basic biology point of view, Jorge, why we haven't been able to reduplicate this model?
I think there's a couple of reasons. One is, CML is a more indolent disease than, for example, in my world, AML or ALL or lung cancer or pancreatic cancer. Those are much more aggressive. So a failure of the therapy in those instances has very immediate implications, whereas in most instances, CML, a failure of a therapy, still gives you the opportunity to try something else, to plan, to do other options, transplant included, which we probably have not used as much as we should in some instances. Now, on the other hand, we are learning that, and historically we've considered CML as this very pure, molecularly pure disease that has this one abnormality. You block it, you're fine. Of course, now we're learning that that's not the case, and these instances where there are mutations in other genes associated with cancer, ASXL1 and others, they're actually pretty difficult to manage, and these patients progress quickly and so on. So that subset of patients, which is fortunately a minority, they are probably more like these other cancers. Probably not quite as bad, but still they're more like that than these nice picture that we have in our mind about CML. You diagnose, you give them a TKI, they're going to have a normal life expectancy.
Michael, any thoughts?
I think that CML was sort of a paradigm for targeted therapy, and we, I think we have other examples that are a bit close, maybe in CLL and some other spaces where we are looking at time duration limited therapy, but it's not exactly the same. I mean, even GIST, where we had a similar target and a similar use of a TKI, we saw multifocal disease and multifocal resistance. So I think it just, as Jorge might have said, I think it just boils down to the genesis of CML, that it's the first human cancer linked to a genetic abnormality, but interestingly, it's so BCR-ABL driven and BCR-ABL persistently driven. 25 years ago, people were estimating clearly we would have had another mechanism of resistance that would have usurped BCR-ABL inhibition by now, and we don't. We're talking today about a more potent, an allosteric BCR-ABL inhibitor rather than whatever the next thing that CML decided to use as an activator.
So getting back to that, I want to come back to asciminib. So Neil, when you sit down with your first-year oncology fellows, how do you explain to them sort of your vision of the pharmacology of CML and why asciminib is different from the other TKIs?
Sure. So the first 5 approved TKIs, are ATP competitive. So kinases, by definition, will bind ATP and hydrolyze one of the terminal phosphate, and then use that, attach that to the substrate, a tyrosine residue on a downstream protein, and the net result of all that is going to be cellular growth. And of course, this is a very effective way to target signaling. But since many proteins bind ATP, there are many kinases. There are not only tyrosine kinases, there are serine threonine kinases, there are lipid kinases. It's obviously very challenging to develop a potent and highly super selective kinase inhibitor that will only hit, for instance, your target of interest. And so all the kinase inhibitors do hit other closely related kinases. In some cases, it's KIT, PDGFR, SRC family kinases, and so on. Now, asciminib takes a different approach. It builds on our understanding of the physiologic regulation of ABL, where the first exon encodes the amino terminus of normal ABL and helps tightly regulate its kinase activity through binding through this myristate pocket, which is not really that close to the ATP binding pocket. And this binding induces this closed inactive conformation where you have these other domains clamping down, as it were, on the kinase domain. You can still bind ATP, but it shuts off basically downstream signaling. And so that mechanism is really pretty unique to ABL1 and ABL2 kinases. And so as a result, asciminib really is very, very selective for these kinases relative to others. And so there's certainly the hope that this may translate to improved tolerability. And obviously, it's a stretch to always assume that a particular toxicity that somebody may have on a TKI is due to kinase inhibition, because these drugs can potentially, interfere with other proteins. But yeah, that's more or less how I explain it. Maybe the last thing I will say is that our understanding of the ATP competitive inhibitors and their vulnerabilities, it taught us about, basically the vulnerabilities for those fall into two classes, those that directly impair drug binding, and those that maybe impair the conformation required for the drug to bind. In contrast, due to its mechanism of action, of course, asciminib is going to be vulnerable to mutations around its binding pocket, around this myristoyl binding pocket. But what we're learning is that mutations located some distance away from this binding pocket confer resistance, and so understanding how this is occurring is important. But the leading hypothesis is that because asciminib basically reinforces or induces this conformation, this physiologic conformation, that conformation depends on a lot of individual contacts between these various domains, and disturbing or interrupting those contacts through mutation could potentially represent vulnerabilities for asciminib that would not be issues for other drugs. So the good news is we would have other treatments for those, but I think the potential number of escape mechanisms for asciminib may be more than what we've appreciated so far, is likely to be more than what we've appreciated so far.
So interesting. Jorge, anything you want to add to that? And also your thoughts about right now what we know based on trials and also your own clinical experience in terms of tolerability issues, asciminib versus imatinib, for example, asciminib versus second generation drugs.
Well, more than that, because the description that Neil did was just beautiful and very, very informative. But I do want to highlight one thing that he already mentioned, is that this is so much more, this pocket is so much more specific for the ABL, and that's probably why we see less of some of the off-target adverse events. Now, we need to keep in mind that probably some of the adverse events that we see are on target, and maybe some of these things we will continue seeing, but it certainly makes it as clean as you can have, because of that mechanism of action. We also are starting to learn more about these mechanisms of resistance, and Neil also alluded to these. And this graphic that you have up there in terms of the mutations that affect one on the other, generally speaking, they're correct. We think about the myristoyl pocket affecting asciminib, myristoyl pocket mutations affecting asciminib, ATP binding pocket affecting the other tyrosine kinase inhibitors, but we are seeing that there are mutations that are emerging with asciminib that are not what we initially had predicted as being resistant, or where we would have predicted that asciminib would work, and yet they're emerging as mechanisms of resistance. So Neil has done a lot of work on helping us understand why this happens. So I think that's an important thing to keep in mind, that as we continue using the drug, we will have to continue learning about its full mechanism of action and mechanisms of resistance. And I also want to bring up the point that we understand a lot about mechanisms of resistance through mutations, Many patients don't have mutations. Many patients don't have detectable mutations. And that, the mechanism of resistance for those patients, we understand it much less. I alluded earlier to the mutations in other genes, and I think that explains some of them. But it is an area, and it is not an insignificant number of patients where we don't have a mutation, and yet we don't know why the patient did not have a good response to the therapy that we predicted that would have worked.
Here are some of the data that Jorge presented. Of course, the ask for first data just presented. But Tina, anything you think might, not just for your own interest, but for your colleagues out there in the community, you think you'd like to hear the other faculty discuss and related to what we've just been saying?
No, I mean, I think it's been touched upon for the most part. I think the biggest question, obviously, asciminib is not currently approved, but just in general, with respect to CML management, I would love to hear about their approach and how they counsel patients on the different options for TKIs that are available in the frontline setting, management of, some of the more common toxicities that we see up front, and, just their general approach when they switch. And sort of their treatment goals for younger versus older patients.
A lot of that's going to come out in the cases, but I think that might be a great way to sort of get started, Michael. So first of all, can you talk a little bit again about some of the things that you saw in the first line trial that you thought were of interest, what you're looking for as the trial matures further, and also Tina's question about right now today, the nature, we'll get into this more, but globally, how you think through discussing upfront treatment with patients.
Sure. So if you just look at the trial, first the design question. So I did like the design. I wish it was randomized to all choices, the entire trial duration, but allowing for an investigator's choice to be predetermined and then a coin toss and then asciminib versus your best drug. I explain it to patients. It's like going to the track and saying, I don't want to run against that horse. I'll run against anyone that's willing to race me. So that was a good design to give an analogy. Frontline, we've set milestones that we expect to be benchmarks in our trials. Major molecular response as an early landmark. And that was the primary goal of the trial. In clinical practice, we don't necessarily demand that patients get an MMR at 12 months, but we aspire to have patients get into early MMR because it's very protective. It really limits progression, and it gets patients generally to higher odds of getting into deep molecular remission. So showing superiority versus imatinib and numerical improvements over second gens, that was important. That was, good historically compared to our other trials and really drove the message home. But I think a lot of people are almost equally or even more interested in the safety and tolerability because we know we have great therapies. Jorge highlighted that, imatinib's still a great drug. So I think the fact that tolerability was in some ways a little better with asciminib, some of the nuisance side effects, the non-morbid toxicities weren't there. I think the second gen versus asciminib with regards to any cardiovascular adverse events in the cardiovascular cardiopulmonary space being basically, dead even and very low was very encouraging. I think it told us that we didn't have a new signal here. Asciminib's going to be on the safer side. Of course, we want longer term follow-up, but I think it delivered two hard messages that it is clearly better than imatinib. It is likely better than second gens, maybe perhaps not, on a case-by-case basis, but it's got a better likelihood, and you're not going to bring any safety issues to the table. So how do we use that now? I think if you look, CML can be pretty complex, obviously, clinically, and I think we often start to get down the road of, intolerance and resistance can often be dual agendas or competing agendas or overlapping agendas. So I thought asciminib made a nice addition to the armamentarium by being a safer alternative compared to ponatinib in later lines of therapy. When you had a patient who was resistant to second generation TKIs, there's been this message about recycling second generation inhibitors really didn't get you very much long-term response or benefit, and you needed to move on to ponatinib. But there was always hesitancy regarding the risk of ponatinib. That's generally for resistant disease. Intolerance is always a bit more of a gray area, but they're often overlapping. So what I would say asciminib did is give us a clear option for the patient with resistance and intolerance that was mixed, and it also gave us the ability to use asciminib hopefully, in the earlier lines of therapy? I mean, as it is continued to be studied, can we use it as a second line inhibitor? And of course, we're all waiting for frontline approval.
So with that, I'm kind of going to turn this over to Tina and Amanda to present cases and query you about those. So let's start out with Tina. You've got a young patient, a 45-year-old man. What happened with him, and what would you like to hear the faculty discuss?
Okay. Yeah, so this is a patient I actually met on the inpatient consult service. Young guy, really minimal medical comorbidities, construction worker, used to doing a lot of hard physical labor, who had been doing well until a few days prior to admission, when he basically presented with GI symptoms. And he's had them in the past, the GI symptoms, and they were evaluated. Essentially, his workup was negative. They did a CT scan in the ER, which showed marked splenomegaly. You can see it on the image here, but it measured 20 centimeters by 9 centimeters by 17 centimeters and was obviously very palpable on exam. His CBC showed a white blood cell count of 225.9, and that's why they consulted us. When you looked at the differential, it's what you see here. It's basically white blood cells in various stages of maturation, which looked very consistent with CML. Hemoglobin was fine at 12.1. Platelets were 286. The only other CBC I had on him was from 2 years prior, which was totally normal. He denied B symptoms, just abdominal pain and distension. I only saw a couple of blasts on the blood smear. He got a bone marrow examination, which confirmed what we thought he had, which was CML with just translocation 922 and no other secondary chromosome abnormalities and less than 5% blasts. So I elected to start him on dasatinib, 100 milligrams a day, about a little over a year ago. And you can see all of his PCR values since I diagnosed him. So he was responding actually quite well. So you can see where he was in April. His BCR-ABL-IS was around 48%. And then 4 months later, it dropped to 1.5% and continued to sort of decline. And so he was doing okay on dasatinib, but he was experiencing some joint swelling and pain, and actually ended up being diagnosed with hemorrhagic prepatellar bursitis 3 months after starting dasatinib, and had an arthrocentesis. He had it recur in a few months later, but it was managed conservatively. So, in this young guy, no other medical problems. I just wanted to see if you could comment on your approach to TKI selection in younger patients like this. I know one question I always get in young patients with CML when I'm going through the different available options for TKIs is which ones are the best. And so I have my own spiel, but I would love to hear how you discuss this with your patients.
Sure. So, I think many of us have been favorably impressed by the second gen TKIs, especially in younger patients. One reason is because of the greater likelihood of getting to deeper responses, which could enable successful treatment-free remission. It's not dramatically higher with the second generation drugs, but it is higher. And if you have somebody this age, and you have an opportunity to potentially spare them decades of treatment and exposure to treatment, then that's quite appealing. So I generally do opt for second generation drugs in younger patients, certainly. And we do feel that dasatinib and nilotinib have are very similar in terms of efficacy. There's been a trial to actually demonstrate that. Bosutinib we know a little bit less about because it came later, and we just have probably less experience with it in the frontline setting. In part because nilotinib and dasatinib are excellent options. For historical reasons, I have a lot of experience with dasatinib, and I just think, if I had to take a drug twice daily on an empty stomach versus once a day with or without food, I know which choice I would make. But, I just put them all out there on the table for the patient and describe, what we know about them, what the risks are of one drug versus another. And I involve the patient in that decision. But yeah, my preference would definitely be for somebody younger like this, a second generation drug.
Neil, And this same patient turns to you and says, Doc, I heard about this new drug that came out. I know, I mean, it's not approved and all, but what would you do if it were you?
Well, I would say at this point, because it's not approved by the FDA, so I think it is entirely appropriate to start a second generation drug. If asciminib is approved in the not too distant future, and if the patient is either not responding well or is not tolerating treatment well, presumably once asciminib gets frontline approval, it already has third line and beyond. Presumably, it will also get second line approval at that point. So it could be, an easy switch in the not too distant future is what I would say.
So, Michael, why don't you take Tina's second question? Tina?
Yeah, so as I mentioned, this patient generally tolerated dasatinib okay. His spleen started going down. You can see his PCR responses here, which I thought were excellent. And so when he developed these joint pains and these bursitis symptoms, we had several discussions about how to manage them because I wasn't quite, I couldn't exclude that this was related to dasatinib. And so the patient and I had several discussions about potentially holding dasatinib and seeing whether or not his joint effusions would resolve, but we did not because the patient was worried he would lose his response. So I would just be curious to know if you would have considered holding the dasatinib in this patient at some point.
I'll have to admit, I'm pretty worried about this younger patient with really robust disease, pretty, high risk presentation. I really can't see how well his PCR is, but did he hit a milestone or not?
He did. You can see at 7 months, he was at 0.063.
Very good. Very good.
Yeah.
Okay. So I think that's where the money is. So if someone is responding well to therapy, managing toxicity becomes a little bit obviously easier. So in an MMR, I think if you wanted to do a withdrawal and re-exposure challenge, given this inflammatory toxicity which he's having, bursitis sounds a little bit like some of the other things we see with dasatinib, with pleural and pericardial effusions, sort of lymphocyte-driven, inflammatory, off-target effects. Sure, I think the question you'd have in your mind is, well, where do we go from here? Let's say we say he's dasatinib intolerant. Then you're looking at maybe moving laterally within the second generation group. I think bosutinib might be a good consideration there. Maybe it would have other toxicities to overcome, but it wouldn't have exactly the same. The other important point to make is dasatinib there is a dose flexibility, I would say. There's reasonable data that 50 milligrams may even be, an optimum dose. I think that's a debatable point. I think there's, one can make a strong argument for, one can make a, sort of a conservative argument against that it hasn't been put in a randomized trial. So lowering the dasatinib dose could be your path forward if you did have a drug hold and you said, oh, I'm relieving his adverse events, he's still in response. So you have to work with the patient, but you want to be careful in a high-risk patient like this. I think he's prime for developing resistance or rapid regrowth kinetics given how he presented.
So, Amanda, in a second, I'm going to allow you to ask any questions about this case you'd like to see the rest of the faculty discuss. But first, Tina, can you present to Jorge your third question?
Yeah, so this is all the pre-asciminib data and everything. And so I generally tell my patients that if you're going to have toxicities on these second generation TKIs, they're probably, they can happen anytime, but, we typically see them early on and they usually resolve. And this patient's arthralgias and everything, they did resolve. Like he is doing really well now clinically and has absolutely no concerns. The only thing is that he's due to see me actually very soon. And his last PCR that was checked showed a very slight uptick in the IS percentage. It was previously 0.063 in January, and then it went to 0.146. So it did go up. And my question is, you know all about his presentation, as we've talked about. It's an aggressive presentation. And so what would you make of this result? At what point would you repeat I mean, he's going to get his PCR repeated. He's due to have that done. But at what point do you check for resistance mutations in these patients? At what point in their molecular monitoring do you consider switching?
Jorge?
At this point, I don't make too much out of this uptake. It is modest. It's clearly not quite a 1 log increase. So the tests have a coefficient of variability. Many labs around half a log or something like that. So I tend not to jump into something radical after just a small change like this. Obviously, the trends are more important, and particularly early on, you see a lot more of these bouncing around, and I want to see the trends. Now, this is a patient that I would not wait 6 months to check again. I would like to check again in 3 months to see that that is just a minor variation and not a clear trend going up. Now, if this had been more like the initial, if it was a 40 or something like that, well, that's different. And you still want to confirm, because here and there we still see occasional technical things with the PCR, but that's less likely to be just a technicality. So I think that we need to be cautious with over-interpreting small variations of the test. After all, this patient is, even with the new one, just above an MMR level, so there's no urgency on doing anything immediate. And there's been some analysis of doing the test too frequent, and because of that variability, you can also be misled by repeating it repeating it in a week or something like that. So I kind of go with 3 months, especially if otherwise the patient is stable, if it's still at a level that I can accept, and this one is one that I can accept. So now when I do it again, I would probably request a mutation at that point, or at least get the sample for the mutation, because once you have the results, if it is really going up, then I do want to know if there's a mutation. If it went down, then I usually call the lab and say, don't run it, that's okay. So, but that would be, if you confirm that the patient is clearly losing the response and now it's above 1, let's say, then it is worth checking for a mutation.
Amanda, any questions about this case or anything that's been said so far?
Yeah, so first, one comment. I've had a few patients who've had a PCR done and then the lab at City of Hope, and we see this drastic, not huge, but enough of a difference to be concerned. So that would be one question I had here, especially at a community hospital. Was this patient tested in the same lab? Yeah, okay. And then 2 questions about upfront management. So in terms of risk models, are we using the SoCal risk model, or what has been the most accurate risk assessment model? And are we checking next generation sequencing in these patients up front now that we have more mutational data?
Neil?
Great questions. So just the first comment that you made was about the lab, and I think that's really important. Since the pandemic, most of my patients I've been managing remotely and sending them to commercial labs. So another question or another comment you had in there was about testing for like myeloid malignancy associated genes. I would love to be able to do that regularly, and unfortunately at this point it can be hard to get insurance coverage for that, in my experience. Sometimes we do, sometimes we don't. I have been trying to encourage the NCCN-CML panel to make that a recommendation, but many panel members basically feel like there aren't enough compelling data yet, what we would do with the information. I personally think we should be more proactive, but, without a consensus, it remains something that's not included in the NCCN CML guidelines, unfortunately, from my perspective. You had a third comment in there. I'm sorry.
Risk models.
Risk models, yeah. So, Generally speaking, I mean, obviously the SoCal is got like the longest sort of traction and so on, and a lot of the studies were done with it. But I think the UTOS is also a reason. But for the most part, in practice, I go with second generation drugs. It is true that you can treat a younger person with low risk disease with imatinib, but for the reasons that we've mentioned, a higher likelihood of getting to deep molecular response, and as others have mentioned, the ability to dial down on the dose and maintain efficacy and improve the side effect profile. I have some patients that I'll start on 100 and not only titrate down to 50, but maybe even down to 20 milligrams a day, and they can maintain their responses. And it's driven by side effects. But I think in practice, I myself don't really use that so much for decision making. Certainly, if they're intermediate or high risk, absolutely. I'll go with a second generation drug.
Thank you.
So let's move on to another case. And my favorite part of the case is 84-year-old woman.
Yes. So this is an 84-year-old with a history of stage 3 colon cancer. She had a resection in 2012 and adjuvant FOLFOX. And then she was incidentally found to have a white count of 20 to 30,000 with a left shift. She did not have increase in the peripheral blasts. Her basophils were about 4%. Cytogenetics, peripheral blood was translocation 922, and then a Mauro showed chronic phase CML. Her spleen was not enlarged. I started her on imatinib 400, and she really just did not tolerate it. She was anemic, thrombocytopenic, periorbital swelling, not eating much, and edematous. So I switched her to dasatinib, 50 milligrams daily. She ended up with effusions with that, and we dose reduced her down to 20 milligrams daily, which she remains on. She did hit her time points with all of this, and her transcript level is low, and she's tolerating everything well. So my plan is really not to achieve a TFR in her. However, I'm wondering about the dosing and if we feel this will provide relatively long-term good control.
So, Michael, any thoughts?
Sure. So I think we maybe could have called this one in the air. You had an older patient who had a previously chemotherapy-treated bone marrow who had, excessive myelosuppression. So that is not shocking. I think that's part of treatment effect. So sometimes you can work around it. Sometimes, lower dose imatinib or hold and restart. But on the other hand, you switch to dasatinib with a dose that's probably got, again, pretty convincing data, maybe better tolerated. The toxicity still came, and pericardial effusion is a more ominous adverse event on dasatinib in my book, and maybe linked with pulmonary arterial hypertension, et cetera. I think back to the phase 1 study of dasatinib, where 40 milligrams was really when we started to see activity. But if you look at her PCR, and you look at the fact that if she's on 20 now for a couple of years and is doing well, this is a clear-cut example of where you just want to keep the patient out of harm's way and not do any harm. TFR is lovely, but at 84, if you run her to the finish line of her normal life expectancy with a low-dose dasatinib in major molecular remission, I think you've done really well, and I wouldn't change a thing.
Tina, how about you bring in your 85-year-old lady?
Yes. So in the same theme of older adults with chronic phase CML, I take care of this patient who is 85 years old. She has a history of atrial fibrillation and has had 9 ablations and has a pacemaker in place. She has chronic baseline renal insufficiency with a creatinine that runs between 1.2 to 1.3 and multiple skin cancers. She was diagnosed about 6 years ago with CML amidst workup for just incidental leukocytosis. She was otherwise feeling well. Around that time, she had atrial fibrillation as well, and she thought it was CML related. She started imatinib 400 milligrams daily in August of 2018. And she kind of auto adjusts her doses based on her blood work without really telling anybody. But at some point, she ended up achieving a major molecular remission. And then she saw that her creatinine was going up, and she kind of did some of her own reading and saw that imatinib could do that. So she self-reduced her dose to 200 milligrams daily, which is what she was taking when I saw her. Her PCR started to uptick a little bit. The values that you're seeing here, again, and I'm sorry for the small print, do show that that over time, while she was on the 200 milligram dose of imatinib, her PCR started going up, and she reluctantly went up to 300 milligrams. She consistently tells me that her, her goals are to. She doesn't necessarily need to achieve a perfect response. Like, she just wants adequately controlled disease and really minimal toxicities. So I was just hoping that you could comment on your treatment approach to older adults with CML and how stringent you are with respect to achievement of the treatment milestones in this age group.
Can you talk a little bit more about this woman as a person, what kind of work she's doing or has done? She has a kind of pretty proactive approach to treatment, interestingly.
No, she is 85 and she looks fantastic. I mean, she's very fashionable. She consistently tells me she is from New York City, not from West Virginia. She's a retired teacher. And so she's, kind of on her own. I mean, she's kind of very self-reliant, splits her time between West Virginia and her home in Palm Beach, Florida. But anyway, very functional.
So, Neil, I would imagine you've seen a few people such as this patient in situations like this patient. Any thoughts?
Yeah, and the one thing that I'll just add to the previous discussion, which I think I can incorporate here, is that obviously, as we all get older, if we're fortunate to get older, and as our bodies start to fall apart, less in medical school, that I'm sure we all heard less is more, right? So less of a drug is necessary to achieve the same level of efficacy, and people are at greater risk of toxicity. In terms of the previous case, I'd say one thing that caught my attention was the rapidity with which side effects occurred. I think that patient was on imatinib for 1 month and then on dasatinib for 1 month before pleural and pericardial effusion. That's really unusual, especially like on reduced doses. Now, again, it could be just that it was, somebody who's got, aged organs, as it were. But I like to check for polymorphisms in cytochrome P450, 3A4, and 5 in such cases, because there are people who are slow metabolizers, and most of these medications are metabolized through those pathways, and so it can be informative not only for CML but potentially for for being treated with other medications, and potentially also for family members to see if they're potentially at risk for excessive drug toxicity. So I like to try to send that. But so back to this patient, certainly patients, sometimes will have their own ideas about or how much drug to take, and will experiment a little bit. I think that in this particular case, as you mentioned, the patient responded really well to imatinib. Obviously, a rise in serum creatinine at age 85 isn't necessarily due to imatinib, but it could be. And so, 200 milligrams, the number has been coming, the PCR number has been coming up a little bit, but really for the most part over the last year or so, it looks like it's been quite stable. So I'm not really so concerned that there's a drug-resistant mutation causing this rise. I do think it's probably the lower dose. I would, probably feel a little bit more comfortable if she were potentially switched to a low dose of a second-gen drug. So I might go to 20 milligrams of dasatinib, for instance, or maybe 100 or 200 to start with of bosutinib, or maybe 300 milligrams once a day of nilotinib, just to and then dose escalate as needed and as tolerated.
A question for Michael in terms of a little bit more about how he thinks through quote, older people. And I will say, people say age is just a number, but, statistically, in terms of life expectancy, 85 is very different than 92. That's very different than 78. And also, again, you have the patient's not only health profile, but also, as evidenced by this case, whether or not they want to be involved, and if they do, what their thoughts are about it. But any thoughts about this last question? And also, anytime people bring up treatment-free intervals, the first word that comes out of their mouth is young people, and of course, but I think older people would like to get off treatment too. But anyhow, Michael, any sort of art of oncology and CML thoughts?
I would say it's complicated, Neil, but my personal view is that I want to be treated like I'm 19 when I'm 99 myself, but that's maybe a little bit of a personal bend. So I think it's probably just got to be a discussion. You have to really find out what the patient's goals are and put everything on the table, including TFR as an idea. But then you have to obviously be a good physician and assess their comorbidities and keep them out of trouble. I don't think it's our job to be too paternalistic to say, well, we're not going to be thinking about a TFR here. That could be just disturbing to a patient here. Like, how come we're not thinking about getting me off this treatment? I hate taking pills. I already take a bowl of pills every morning. I don't want to take this drug any more than I have to. So the older patient, as many of my colleagues have nicely summarized, clearly less, maybe more. Clearly, the adverse effects may be more, they way heavier. It's clear from, for example, the asciminib frontline trial. If you look at the age of those that were sort of allocated to Amanda, it was older because we want to be more protective. We want to take the approach of being safer in our older patients. I'll be devil's advocate and say here that in these older patients where we have adverse effects and if response is not ideal, I think Neil's comment, low dose second generation TKI, there might be a place for asciminib or even lower dose asciminib in that setting. We haven't really studied that question, but that's an intriguing thought because I think it's quite a safe drug, and it could be for that fashionista patient who maybe wants to be availed to TFR so she can have more winters in Palm Beach than her peers, So I think this is, like I said, it's complicated. It's a discussion. Ask goals, assess comorbidities. Keep all the options open. Don't be afraid to have a gentler touch in any patient. The younger patients can suffer greatly with adverse effects too, and might need the same touch.
Such great thoughts. All right, let's go on to another case. Amanda, you have a 50-year-old woman.
Yeah, so this is a 50-year-old female with chronic phase CML who was intolerant of dasatinib. She was treated with imatinib. She achieved a major molecular response, and she came to me as a consult for when is the optimal time to try to achieve a TFR. So she was on the dasatinib 100 milligrams daily. She had a dose reduction to 40 milligrams daily due to nausea. And then it was titrated back up to 100 milligrams, but she was extremely tired, had a rash, she was nauseous and diffuse edema. So she was put on imatinib, which this should say 400 milligrams daily. She was interested in the TFR and had been on treatment for 3 years. You can see the trend of her transcript here on the right, and it was somewhere between MMR 3 and 4. She actually, we discussed that some of the data showed that the longer that you're on the TKI, perhaps the more likely you are to achieve a successful TFR. So we decided to keep her on for 2 more years. And then after a lot more discussion, we were interested in trying a different second generation TKI, and we put her on bosutinib, 200 milligrams daily. She does have diarrhea once or twice a day. She's taking Imodium pretty much once a day. It doesn't bother her, and she is fine with it as long as it doesn't cause her any long-term damage to her bowel. So she actually asked me recently, would we go up on the dose of the bosutinib, but her transcript level already came down after a month being on the 200 milligrams, so I did not escalate it. So my questions are TFR after imatinib, and then the management of diarrhea with bosutinib.
So Jorge?
In terms of the TFR after imatinib, I wouldn't have tried it. I like the idea. I like the concept of MR 4.5 rather than MR 4. I think of course, there's a tight correlation between duration of therapy and duration of the depth of response. But generally, the best studies, the best results have been with in the studies that have used MR 4.5, and also the data. We reported that a few years ago, and there's been more data on that showing that the longer the duration, the better. Now, it is a discussion with the patient. I do accept 2 years, but it's a discussion with the patient. My minimum is 2 years. That is acceptable. And if you want to try, this is the data. The optimal is longer, and this is the data. And you pick. It's your choice. Just need to understand what are the pros and cons of one versus the other. But certainly, my preference would have been to not discontinue at that point with the imatinib when you only had MR 4.5 probably twice there, and it's just a month difference. So it says it's essentially once because it's that test is the same. And then you had probably MR4 one time, that July 2023. So really, this patient never quite made it to a full criteria for TFR. So I agree with not having attempted that when the imatinib. Now, in terms of the bosutinib, and this is still early on the bosutinib, and the patient the diarrhea may improve over time. After a month or two, you still see some diarrhea. This doesn't seem to be too bad, and very frequently it improves over time. And obviously, what 1 or 2 bowel movements a day is for a patient is again a physician, a patient's decision, because for some lifestyles, a couple of bowel movements, if they are very loose, and that may be too difficult to manage for certain individuals because of their lifestyle, because of their preferences, whatever. Whereas for others, that's quite acceptable. So this patient seems to be okay with that. I think that's okay. In these instances, very frequently I see patients where eventually you can indeed try to go up in the doses. I wouldn't do it now because, as you said, there's already been a drop in the transcript level, so I don't need to push the dose. I need to see the outcome of the dose that I'm using. But if there was no improvement, then yeah, you could consider increasing the dose and see how the patient feels, what happens with the diarrhea. Now, let's keep in mind, best case scenario, 10 years on the NEST and D, only about half of the patients meet criteria for TFR. So, we need to recognize that no matter how much we push with these drugs, half of the patients, at least half of the patients will never get there. So that's a reality, unfortunately, with the drugs we have today, with the approaches we use today.
Tina, anything you want to ask about this?
Yeah, I think, I have not attempted TFR after imatinib either, but I know other people have and have had variable success with that approach. The diarrhea on bosutinib, I was just curious to know how that was managed and whether or not the Imodium ended up taking care of things, or did you end up doing another dose reduction, or, just...
She was taking the Imodium multiple times a day. It was up to like 2 or 3 times for the first couple of weeks, and then it did settle down a bit. So I did not reduce her dose because I expected at least some diarrhea to start with. In terms of the question of does this cause damage to her bowel long term, I can't really answer that one with certainty, but it seems like it does not. I don't know if there have been any cases of drug-induced colitis or any sort of colitis that needed to be managed more significantly.
Neil?
If I could just chime in. So I think this is somebody in whom I might consider either a reduced dose of nilotinib, if she hasn't tried that, if there isn't a reason not to try that, or asciminib, because if it's looking, you can look at this in 2 ways. One is that, as Jorge mentioned, maybe this is somebody who's never going to meet formal criteria for TKI withdrawal, in which case maintaining quality of life is really important. And so I would, if that were the case, then I would just basically say, let's switch you, just try switching to something else and see if it, if your quality of life improves, and there's every expectation that you're going to maintain this level of molecular remission. The other thing I would say is that she's been really close to MR4 consistently. But these ones that are not MR4 are like 0.11 or 0.12. I don't know that I would put so much stock in the test, because if she went to a different lab, it might be a little bit lower, it might be a little bit higher. But if the patient was really motivated to stop treatment, as long as they understood that it would be formally deviating from the recommendations for stopping, I think the risk is low, especially if you continue to use loss of MR3 as your threshold for resuming treatment. But I would obviously involve the patient in that discussion, and because these thresholds are arbitrary. They're a byproduct of our base 10 number system at the end of the day.
Michael, agree, disagree, or in between?
I might say in between. I like Neil's point about the close to being MR4. I think that time on treatment is probably going to be something to look at in this patient's case. I also agree with the idea about switching, because living on Imodium is not a great lifestyle if you can help it, if there are other options. And there's some science behind why some patients have PCR signals that look like they're still fairly positive, but they've been stable and low, and they may still be amenable to TFR. We may be looking at BCR-ABL signaling coming from lymphocytes, B and T cells. It's not really for prime time, but it's really intriguing because I don't know if we have a clear answer that the PCR level is as informative as we'd like it to be. Yes, we have data on MR4.5 versus MR4. Yes, there's data on digital drop PCR being able to predict patients with greater TFR success, but I don't think it's crystal clear. I think there are some patients that we can't call. So I would remain hopeful that TFR could be an option, and I encourage optimizing her day to day, in the present.
All right, let's bring in another case. Tina, you have a 57-year-old woman.
Yeah, so I had a 57-year-old woman who was diagnosed with CML like 16 years ago and initially treated with imatinib, did very well on it from a disease standpoint until 2012. She'd basically been on it for 4 years because of diarrhea. She was dose reduced to 300 milligrams and was briefly switched to dasatinib, but due to severe fatigue, went back on imatinib for 400 milligrams a day and thought it was fine. And she was able to obtain and sustain a deep molecular remission. So we fast forward to January of 2022, and because she has had such a deep molecular remission, I don't have those values from eons ago, but they looked similar to what you're seeing on the screen, which is basically MMR 4.5 or a CMR. And so she ended up stopping imatinib because she met discontinuation criteria and was bothered by arthralgias. Soon after, like maybe a month or two after she stopped the drug, she developed profound fatigue. She's a vice principal and has a lot of responsibilities related to that, as well as bone and joint pain, shoulders, hands, like everything was just aching. And so she was diagnosed with TKI withdrawal syndrome and was treated with steroids and did temporarily okay on the steroids. But after the steroids were removed, her symptoms sort of came back. And so it prompted reinitiation of treatment with her TKI, and her symptoms completely resolved after she started the medication. And she's kind of in this place where she does not want to be on her TKI anymore, but she also does not want to have a flare of those withdrawal symptoms. And so over time, we gradually reduced her imatinib dose kind of per her preference. preferences, and she's now on 100 milligrams daily. That's been since January of this year, and she just called my office 2 weeks ago, basically saying that she has, recurrence of the fatigue and the joint pain similar to what she had when she originally tried coming off imatinib. So my question is, how often have you personally seen TKI withdrawal symptoms in your practice, and how have you managed those patients? And whether you've been able to identify any, patient or disease factors that would predict for this.
Jorge?
Well, it varies how the frequency varies. There's been reports that say that it's 30 to 40% of patients. Some, I've seen reports as high as that. I don't think it's quite that high. Now, it could be that you have a very low threshold to call something a withdrawal syndrome, and then, many patients qualify for that. To me, it's more, 15 to 20% of patients that have a withdrawal syndrome. And in the overwhelming majority of instances, it's either minimal, that it doesn't need intervention, or resolves or responds well to nonsteroidals. Rarely do I need to use corticosteroids. But I do have a handful of patients, but probably more than a handful, where the only thing that has worked has been to resume the TKI. And I've done, similar to what you've done here, find what's the lowest that they can take. And sometimes it takes very little, but some patients you need to keep going up until it's enough for the symptoms to go away. And those are challenging because in this particular patient, for example, the patient wants to come off. On the other hand, you don't have, perhaps the quality of life with the withdrawal syndrome is worse than the quality of life of what she may have been experiencing with the TKI. I recently had a patient who was in the medical field, and she was on a wheelchair. She had to stop working and all of that because of the withdrawal syndrome. So she's back on her TKI, and she's now doing all her normal activities and so on. And she just acknowledged that she's going to need to continue on that. These are very rare, very infrequent scenarios. But when they come, many times that's the only thing that I know that works in those patients.
Michael, any comments about your experience, and also what's the presumed pathophysiology of why this happens?
I'm glad you're asking, Mike.
Yeah, because I'll have a crystal clear answer. I think we postulate these short-term briefs, 6 weeks out for a few weeks or months, some arthralgias and inflammatory symptoms to KIT to KIT activation. You have an off-target KIT inhibition. You don't have KIT inhibition. So if you have KIT over activity, over signaling, that's an inflammatory. Mast cells, mediators of inflammation, could be a mechanism. That's why we recommend antihistamines as part of the first thing is to tell patients if they have symptoms. My immediate reaction in this case was, though, that how is it that someone didn't have a condition, they start on a TKI, and then they now have a condition that requires the TKI in the inflammatory autoimmune rheumatologic space? So I definitely get people over to rheumatology and see if we've either unmasked through TKI exposure, or we sort of, something developed, and ironically we were treating it, and now it's quite manifest. And sure, resuming in the TKI is not unreasonable, especially if it's a low-risk TKI like imatinib. But I've had a couple of, I think we all have a handful, as Jorge said. I don't know if it's better, but I've diagnosed people with other rheumatologic conditions, and they've had appropriate treatment for that rather than having to stay on the TKI as an alternative. I'm not sure how often that is. There may be some patients who have some sort of shift in their phenotype where the TKI is the solution, but I've seen the opposite. I've seen lupus and I've seen other conditions sort of become manifest. Some of the TKIs might do it. I think dasatinib, but not to again cast aspersions. I think it does have an inflammatory immune potential mediator. I see toxicities linger beyond it, so that might be another way to look at it.
Good point. Yeah. All right, Amanda, 54-year-old woman with accelerated phase CML.
Yes. So this is a 54-year-old female who has accelerated CML. At the time of diagnosis, she had clonal evolution. She also had a translocation 1-4 and an ASXL1 mutation. So she initially presented in August of 2022 with massive splenomegaly, 30 centimeters, a CBC with a white count of 411, hemoglobin of 8.5, platelets 366, basophils were 13%, blasts of 10%. She was started on nilotinib, 300 twice a day, and then quickly had a dose reduction to 150 milligrams daily with severe pancytopenia. Her transcript level at diagnosis was 35%, and she was pancytopenic for 5 months at the time, and she was found to have a CYP3A polymorphism. She was started on asciminib, 80 milligrams daily at that time, and was pancytopenic again for another 7 months. She was transfusion dependent, and then she was again off her TKI. Luckily, we didn't get any infections. Now she's on asciminib, 20 milligrams twice weekly. Her ANC is about 1, and her platelets are 20 to 30,000. She's on Nplate. And you can see that her transcript level is still anywhere between 30 and 50%. She does have the ASXL1 mutation, which is hovering between 5 and 10%. And there were a few other values, maybe at UCSF or different hospital, that were around the same here. So my questions about this case are the interpretation of the ASXL1 mutation, and how you really monitor clonal evolution in all patients. If you start with just a translocation 922, are we periodically checking, cytogenetics or just transcript levels? And how should we manage patients with CYP3A polymorphisms?
So, Neil, the two of you shared the case, or what happened?
Yeah, so this patient was originally, she's from San Diego. She was originally seen at UCSD, and I kind of got involved a little bit later after the prolonged cytopenias. So I've never actually seen her in person. I've only, seen her remotely. She was reluctant to have transplant. She was obviously counseled at UCSD. I think she sought out another opinion or another center, and that's how she saw Dr. Blackmon at City of Hope. And I think if she's going to have a transplant, she said she will have it at the City of Hope. And I've certainly told her that I'm not encouraged about her long term, or that I'm not encouraged that things are likely to change for the better. If she stays on medical therapy, obviously if she wants to, and hopefully things will be stable. But it is concerning that she's got these other mutations. The GATA3 we think is germline, because that anyway. But yeah, the ASXL1, and it hasn't risen. But at the same time, it's there. So,
any teaching points you'd like to make about this case, Neil, and anything you'd like to see Jorge comment on about the case?
Oh, I would love to hear anybody comment, but so the CYP3A4 polymorphism again. I mean, I don't know how often people are checking for this, but again, what piqued my interest in that was just the rapid and prolonged pancytopenia. Obviously, one worries about the underlying health of the bone marrow environment. There's no reason a priori why hers is so so ineffective at restoring hematopoiesis. But yeah, and I guess, I think Dr. Blackmon asked me about suggested transplant regimens, and once they get to transplant, I just hand them off. So I don't have any thoughts. And so I think if, people's thoughts about that would be great as well.
Jorge?
Well, first, I think that, this is a patient for transplant. I think that, there's a couple of elements of why this may be happening, and certainly the polymorphism is a possibility. But I think that the fact that there are all these additional mutations These patients tend to get more myelosuppressed. This is probably one of these instances where you have these cytopenias of unknown significance, and they frequently come with molecular abnormalities and so on. And in this case, it's together with a diagnosis of CML. You manage with whatever you can, and this patient is unlikely to respond. And if she does, it's probably going to be a very short-lived response. So, we talked a little earlier about these mutations and whether you should be checking initially at the time of diagnosis or not. And there's considerations why you could or could not be doing them up front. But on a patient that goes through this path, I think you always need to check them, because that is where you see an overrepresentation of these patients. And what I'm doing is moving my transplant up frequently much earlier in these kind of patients, because we know that this is not going to be better with TKIs. Actually, with asciminib, we do have data that patients that have these type of mutations progress more on asciminib. They progress more than patients that don't have those mutations. So we already have data with asciminib showing that this is a bad scenario for asciminib as well.
The last thing I'll say is with the variant allele frequencies, one of the things that I mentioned to the patient that we unfortunately don't know is, is the ASXL1 that's there at low frequency now, is it in her CML cells or is it in her pH negative cells, right? And so you could imagine that part of her inability to restore hematopoiesis may be because she's got some underlying MDS, and that's kind of like part of why I think we've been like trying to, in the old days we would do karyotypic analysis, look for trisomy 8 or other changes, and now of course we can feel a little bit better that we're looking a lot more at a more granular level at what may be evolving, but it's still really early days. And yeah, this case definitely has been very, very challenging, and I don't see long-term improvement with medical therapy, unfortunately.
Jorge?
Well, and I was just going to point out that in addition, she also has a DNMT3A mutation. So I think it is very possible that this patient has something else hematologically there in the non-CML clone.
I did check
Amanda?
a bone marrow. A recent bone marrow did not have MDS, but morphologically at least. But yeah, I think that will impact also the decision about conditioning regimens and how to transplant her if we think she could have MDS as well. Our center, the older data using BuSci and tacromethotrexate, we've started to do fludarabine and melphalan with tacro-sero standardly here, but the patient is very afraid of GVHD, as am I. And she's interested in pursuing an ORCA-T or ORCA-Q trial. So that's something we're considering, or post-transplant cyclophosphamide, though the experience with that is relatively limited.
All right, let's go into another case. Tina, you have a 73-year-old lady.
Yeah, so I also saw this 73-year-old lady on the inpatient consult service who was diagnosed with CML in 2012 and was on imatinib for about 7 years before she was switched to bosutinib 500 milligrams daily because she lost her major molecular response on imatinib. She was able to achieve a complete molecular remission on bosutinib as of June of 2019, but had trouble with pleural effusions, which were attributed to bosutinib. She had a couple of thoracenteses and was dose reduced to 300 milligrams daily of bosutinib, and was taking it until last spring when she was again admitted to the hospital. And that's when I met her for the first time, because she had recurrent pleural effusions, and she was done with bosutinib at that point. And we were having this discussion about where we go from here. We talked about TKI discontinuation because she had been in a complete molecular remission for several years, but she was worried that her CML CP-CML would flare up off of anything. And so I recommended asciminib, and she started 80 milligrams of asciminib 2 months later in May. And she called into the clinic because she said that she had worsening shortness of breath on asciminib, and she thought it was all asciminib's fault. And so we held her treatment for 2 weeks, and I called her again, and she said that she was feeling a lot better, and I instructed her to resume asciminib at a lower dose of 40 milligrams daily, but she didn't do that. She was going on vacation with her family. She was like, I do not want to have any TKI related problems when I'm on vacation. I'll start it when I come back, but she never did. And so now she's been off all TKI therapy since June of 2023. She's still in a complete molecular remission, no recurrent effusions, and is very happy with her quality of life. So my question is, asciminib, I think its biggest selling point is its tolerability over TKIs. And so I just wanted to know if you have seen people tolerate it poorly and how you've managed those toxicities and your approach to dose reduction.
Michael?
Well, I was just going to comment on the case. This is sort of TKI, UDI, like unanticipated drug interruption. I think we all have probably a handful of those cases too. And you did a great job getting her in remission with dasatinib. So that really, because that period of lack of MMR and imatinib, that could have been a stumbling block, and I'm glad she's stable. So asciminib's not perfect. I think I always describe it as it pulls in some adverse events from all of the drugs we've seen, lipase elevation, hypertension, thrombocytopenia, fatigue, arthralgias, myalgias, etc., hypersensitivity. You're going to have cross intolerance, I think, with certain patients. If we look at why we have adverse events, are they on target or off target? Hard to separate them entirely. So I would have liked to have seen her try the lower dose of asciminib to see if it was a dose dose related toxicity. But again, it's a happy ending. So asciminib, well, it's very well tolerated and has a more lean side effect profile, and mechanistically may have less off-target effects. We still don't understand, where's the pancreas target that all of the drugs basically across the board have some risk of lipase elevation. Well, maybe it's something similar in the cardiopulmonary space where you can trigger symptoms like this. Not to throw the patient, under the bus, but she probably was pretty worried about starting another drug and having the same toxicity recur. So, sometimes, a thorough workup and a hold and a reassurance might have bridged her, but she didn't need it. So I think we just have to manage accordingly and in an anticipatory fashion. But asciminib at lower doses, I think, may hold some power. We started at 10, 20 milligrams in the phase 1. I think many of us have patients on lower doses from our trial experience that are doing quite well. So wouldn't use it routinely, but I think much like our other TKIs, there may be some room there. And I think your intentions were good and your ending was happy.
Thank you.
I like that. Jorge? Any comments, Jorge?
Just to add to what Mike mentioned, as he said, asciminib is very good, but it's not perfect. And just as a reminder, even in frontline, in the ask for first, there were 5% of patients who discontinued because of adverse events. That was half of what happened with the other TKIs, so it's less common. But even in a frontline setting, when there's no all the background of previous therapies and so on, and it was just one of these and one of that, there's no pattern. But there's always going to be a patient who just cannot take whatever you give them.
This is another one of those cases where the nature of the side effects, pleural effusions with bosutinib, pretty uncommon, especially in a patient that's not had prior dasatinib therapy. So this, again, is somebody, I don't know if she's not taken a lot of medications in the past, but this is somebody that you may consider doing one of these CYP polymorphism tests on. I do have some patients on as low a dose of asciminib as 20 milligrams, and sometimes even like 3 times a week. As others have said, it does have some side effects, and some patients don't tolerate it better than other TKIs. But I'm usually pretty aggressive at trying to maximize quality of life in patients once they're responding well. And so I'm a little bit more aggressive with dose reductions probably than most people, but it's given me confidence that in select cases, less doses and infrequent can be effective and well tolerated.
So a 34-year-old man, Amanda, what happened with him?
So this is a 34-year-old male who developed splenomegaly, left upper quadrant pain, and 25-pound weight loss, prompting him to go to the ER. His white blood cell count was 787, hemoglobin of 9.7, platelets of 425. He didn't have any peripheral blasts and 3% basophils. Bone marrow at the time in chronic phase. He has this 3-way translocation between 1, 9, and 22 in all 20 metaphases. So he had a CT at the time, which was kind of interesting, with huge hepatosplenomegaly, prominent retroperitoneal and pelvic lymphadenopathy. He had a 7.9 centimeter soft tissue lesion and some nodular soft tissue density along the anterior penile subcutaneous soft tissues. None of this was biopsied at the time. This was all done at a different hospital and then came to me kind of as a consult to see if he needed a transplant, actually. And I was a little bit confused about the consult. I rescanned him. He didn't have any hepatosplenomegaly, no lymphadenopathy. He's been on dasatinib 400 milligrams daily. There was a brief treatment interruption because his insurance wouldn't cover the drug. And now his latest BCR-ABL is 0.16. So he met the 6-month time point. At 12 months, he was briefly off treatment. And then now his level is pretty low. So my questions would be, what do we think about a 3-way translocation and these less common cytogenetic abnormalities?
So, Michael?
Where do you guys find these cases? These are breaking some personal records for height of white count.
West Virginia.
Bring your spleen in a wheelbarrow kind of situation.
They come to see me during my first year of being an attending. That's where they.
Well, hats off to you guys for these bringing these forward, and managing them. It's remarkable how well this patient has actually done, because I'm reading through the history and I'm assuming that this might be extramedullary blast phase transformation or a different disease. That doesn't mean that dasatinib wouldn't work necessarily, but it certainly is very high grade, high risk disease. But to get to the question, Neil and Jorge may be able to correct me, but I don't believe that we feel that 3-way translocations like this, especially with certain partner chromosomes, will have a significant impact on disease biology. Because if you still have, ABL fusion, you may have other partners involved, but it may have a non-clinical impact. So I generally treat them like I treat standard pH translocation. That being said, all the other features of this case I would have been very nervous along the way. And obviously you had to navigate gaps in treatment and getting therapy for the patient. So I'm glad he's near MMR. I think that's remarkable. It's taken a while, so that's a bit of a challenge. But again, answering that primary question, I think that was the least of his worries. I think the kinetic growth of the disease might have been neglected, might not have been able to get to medical care for a while. But thank goodness that it worked, and I would continue to look for mutations as you have, because you still have a fairly high disease burden. Might be interesting to look at secondary mutations in a case like this. We talked about this earlier. When are we going to learn from sort of other myeloid mutations and how they affect the outcome? In cases like this, I think when you at the beginning doing everyone may not be as high yield as doing it now, to understand because he's 34, and approaching a better remission. But transplant's probably also something to talk about in a case like this, because if he doesn't get into a deeper remission or clearly into a stable MMR, he may not have long-term success with TKI therapy only. So those are some thoughts.
Jorge, anything you want to add to that?
I would just confirm what Mike said. We looked at these some time ago, and the data mostly comes from imatinib because that was when we started having these questions about these patients, and it was shown that these three-way translocations did not these variant translocations, either the simple or the complex like this one, it did not adversely affect the outcome of patients. They frequently come with that deletion of derivative 9. And both of these things were historically of adverse prognosis with interferon, but they lost their prognostic significance once we started treating patients with tyrosine kinase inhibitors. So you just really need to you can continue following them with a regular PCR and so on, and yeah, I mean these patients responding well, a little slower than you would prefer to see, but I'm okay with that, with the response where the patient is, and I would not do anything different.
Tino, let's hear about this 36-year-old man.
This is a gentleman who I originally took care of when I was working at Ohio State, and who basically followed me to West Virginia. But anyway, he is a 36-year-old guy, really no medical comorbidities. He was diagnosed with CML in 2017 after he presented with a major splenomegaly and a white count of 168,000. His bone marrow biopsy at that time showed pretty like garden variety CML, translocation 922, no secondary chromosome abnormality. It is not my practice to check NGS studies on these patients. He started dasatinib 100 milligrams initially, and he stayed on it for about 2 years, but had numerous treatment holds and dose reductions for grade 4 thrombocytopenia. But his BCR-ABL was trending down nicely, and he met criteria for major molecular response. But ultimately, due to the persistent cytopenias, in September of 2019, he was switched to bosutinib 500 milligrams daily and remained on it for about a year. He had a suboptimal molecular response on bosutinib, so he had Abl kinase resistance testing, which showed the presence of a T315I gatekeeper mutation. He did have a prior one a year before that, which was negative for any resistance mutations. So he was started on 30 milligrams of ponatinib daily, and his PCR improved nicely to 1.88% from 36.7%, and was evaluated for stem cell transplant, but he really didn't want that. He's a young guy, 3 young kids, really didn't feel like he had the time for a transplant. And he actually saw one of you and was recommended to go on ponatinib at a dose of 45 milligrams per the OPTIC study, and then eventually dropped to 30 milligrams once major molecular response was reached. He did okay, but again, his PCR started rising, and he lost his MMR a few years after being on ponatinib. Had a bone marrow biopsy at that time, which showed the T315I mutation on the resistance panel. And then he also had ASXL1 and 3 different BCORL1 mutations, as well as a new inversion 3 on his cytogenetics. And so he started asciminib and was on it for about 6 months before he progressed to blast phase CML. Long story long, he went on to have induction chemotherapy followed by a transplant. He's doing okay right now. And so my questions are, at what point in these patients with T315I mutations do you do transplant versus like ponatinib or asciminib, and is it a given that all of these patients will require a transplant at some point?
So who is the second opinion?
Dr. Cortes.
So we'll start with you, Jorge. Maybe you can talk a little bit about, if you're okay with it, your connection to the case and what your thoughts are about it.
Yeah, well, I mean, I got involved there with the ponatinib, and we do know that with ponatinib and with asciminib, those are is important for T315I. In this OPTIC study, in this randomized study, clearly in the T315I, there's a big difference in the probability of response between between 45 and 30. And then in asciminib, the dose that you need for T315I is 5 times the dose of the non-T315I patients. So they both work in the T315I, but they're dose dependent, clearly. So unfortunately, we know that although both drugs are very good in that setting, it's not 100% response. The response rate with ponatinib, even at 45, it's about 60%. And this patient, well, was not one of those. So now, in terms of the question as to whether I would transplant, at what point would I transplant a patient with T315I? I don't tend to transplant them just because they have T315I. There is an analysis, and it's retrospective, and it's based on databases. So obviously there's that caveat. But comparing the data with ponatinib from the clinical trials to the data from the European Bone Marrow Transplant Registry, the survival is better for patients treated with ponatinib than with the transplant. That is if they are in the chronic phase. So I usually tend to give them the opportunity. Now that was in the days of ponatinib, I would assume that you would expect the same thing with asciminib. If you were to do that same comparison. But I think once a patient has a failure to one of these two drugs, you need to be ready to do the transplant, even they're still in the chronic phase. There's much less, wiggling room there. You may change to the other one while you prepare the patient for transplant, but I think that's less likely to be an improvement long-term, particularly for a young patient like this.
So, Neil, anything you want to add to that?
When the patient lost response to ponatinib, it would have been nice to have another mutation assessment, because if you know that there's, more than one mutation, then really all bets are off as far as asciminib treatment goes. Asciminib could be, there's no harm in trying it, but, at that point, certainly lining up the ducks, I think, for transplants would make sense. And the other thing I would comment on is, 3q26, chromosome 3q26 abnormalities. You said this patient had an inversion 3 abnormality. Those are associated with a higher risk of progression to blast crisis. So if you do detect those in the chronic phase, that's another indication to at least begin the process of transplant evaluation and continue to watch them like a hawk.
Michael?
Yeah, I was just going to echo. I think Neil, he was reading my mind. You dropped a couple of juicy bits in there where the patient at the time of switch to asciminib had the B-core and inversion 3. I think those are, B-core is not necessarily known to be high risk, but is certainly described in myeloid malignancies, and the chromosome 3 abnormalities Neil just covered. Also, the high transcripts, failing ponatinib 45 with high transcripts. We do know that asciminib hasn't fared as well with high transcript patients in salvage for chronic phase. So that would have been the point when the transplant, if transformation could have been avoided, it would have been an option to elect at that point to say asciminib can be started while we prepare you for transplant to see if it has any effect, rather than maybe holding out for longer and allowing. But it probably was pretty quick, I fear. It was just looks like 4 months or 6 months of exposure. So it was in the cards, unfortunately. So lesson learned.
Any other comments or questions about this case?
Yes, I'm just wondering about the transplant regimen. So in a young patient, did he have other comorbidities, or he wasn't given myeloablative conditioning?
I'm not sure. I'm not a transplanter myself, so that's ultimately what he received from his transplant team. He really did not have much in the way of medical comorbidities. So the rationale behind his conditioning regimen, I couldn't really speak to. But ultimately, there were a lot of other, and I think we see this a lot in these younger individuals, these adolescent and young adult age group who are sort of in the thick of life. It's sometimes difficult to manage them due to competing life priorities, and that's general, and that is what happened in this case, because he was referred for transplant multiple times and basically declined until the horse was out of the barn. So just another sort of social aspect of what we struggle with sometimes.
So a couple other things I'd like to do before we finish. First, I want to go back to Tina and Amanda and ask if there are any questions they'd like to verbalize.
I would like to hear you guys talk about your incorporation or thoughts on some of, I think it's the Destiny data with like the TKI maintenance approach. So basically in patients who are not necessarily candidates for TKI discontinuation, but have achieved a deep molecular remission, how often do you just sort of have the dose of the TKI that they're on, and which patients do you consider that in? Do you think it's a reasonable approach?
Neil?
So I will frequently dose reduce. I don't necessarily go by half, but I will frequently dose reduce in patients if they're interested. Now, if a patient has absolutely no toxicity and they're in a deep molecular response and they have no interest in stopping treatment, because some patients don't want to stop treatment, they don't want to deal with the more frequent blood testing required, or maybe they are a little bit concerned that there have been some anecdotal cases of blastic transformation, down the road. It's very rare, but it's not unheard of. And so I will commonly, involve them in the discussion as to whether they want to potentially dose reduce. Many will, because the idea of, being spared drug exposure, even if it's not completely, but just being exposed to less, can be quite appealing.
Thank you.
Amanda? Any questions?
I have a couple of things. First, I think talking about pregnancy management in these patients. So what is your cutoff? Do you go until a complete cytogenetic response or major molecular, and especially in your patients who are in their late 30s?
Jorge?
Well, I'm assuming that you're referring to a planned pregnancy. A patient who wants to become pregnant brings that up to you, and you're trying to help her find the right setting. And I ask that because there are other scenarios which are more complex, which is the patient who's pregnant and while pregnant diagnosed with CML, or the patient with an unplanned pregnancy who's not giving you him or her the time to prepare for when to become pregnant. In that instance, again, it is a discussion with the patient. The lower the level, the better. Because part of my approach with pregnant women has been to be very minimalistic. I don't give them anything during pregnancy. I don't use interferon. So I know the transcripts are going to go up, but usually nothing happens. It's just the transcripts go up. So, but the lower you start, the more room you have for that increase in the transcripts, and it at least gives more reassurance to the patient and also to you. So it depends on what the patient feels in terms of how long they're willing to wait, how immediate is their desire to have a baby, and so on, and then try to get them to the best possible point I can before they become pregnant. So I don't have a specific threshold. I just want to understand from the patient their timelines, their goals, and explain what the approach will be and what I'm expecting during the interruption of the treatment during the pregnancy.
Jorge, can you bring in the other two scenarios? The patient who becomes diagnosed while during pregnant and the patient who becomes pregnant after diagnosis.
The most challenging one is a patient who is diagnosed while pregnant, because by definition the disease is full blown active, and part of that depends on what stage of the pregnancy you are, what trimester of the pregnancy. If it's very early, if it's in the first trimester, you have probably a high white cell count, big spleen, maybe symptoms, and then you have the pregnancy. Again, I am very minimalistic. In those instances, if I can delay any intervention until the second trimester, when most drugs become more safer to use, then I prefer to do that. Some are a little bit more, at least in animal studies, more teratogenic, and there's more data for imatinib, for example, on teratogenesis, and for others like nilotinib. For others, we don't have any data. The other thing is that the problem with interferon in a scenario like that is that it takes way too long to work. To bring the white cell count down, and even more the Philadelphia chromosome, it takes way longer to work. So if I can wait for the second trimester and I need to bring the white cell count down, I prefer a TKI, or if anything, hydroxyurea. I give them very short pulses of hydroxyurea. But the goal is to try to get through the first trimester. And I don't worry too much about a high white cell count. The white cell count is 60. I don't, it's okay. If it's 100, it's okay, as long as the patient is doing well and the baby is doing well. I always work with a high risk pregnancy specialist of obstetrician, so that they can help me monitor the baby and make sure that the health of the baby and the mother are okay, aside from the CML, because it's not just the CML that we need to worry about.
So, second opinion from Michael.
I agree on most of those points. Just to take Jorge's point even further, as low as you can go. So, even best case scenario, you have a woman who wants to get pregnant, she has CML, you're treating her and you're telling her, okay, when is the window going to open? Even if you get to TFR eligibility, then you have a 50% chance of success there. So I'm often at this crossroads with women saying, should I try to conceive when I start TFR? Do I have to wait for 6 months? Do I have to wait for 18 months? It really is probably going to be as low as you can possibly get for as long as you possibly can, following the women's choice and understanding the risks and benefits. I personally do use interferon, although I admit it's slow as molasses and sometimes doesn't work, although I've seen it all. I think I may offer some buffer. I try to get the white count normal before delivery if I can. And I definitely, increasingly, I just literally yesterday got news from an obstetrician delivering a woman who had Amanda that we started in the third trimester because she was diagnosed in pregnancy. Interferon was ineffective. She had just a very stable blood count around 120 to 150. Amanda brought her into hematologic remission, smooth sailing right to delivery, and she delivered a healthy baby boy. So I don't think it's sanctioned by the FDA by pregnancy category, but the aggregate data, nicely summarized by some good registries, shows that Amanda in late pregnancy is probably not very, very much of a risk, but definitely need high risk and careful monitoring.
Very interesting. Neil?
Yeah, I certainly agree that, imatinib after the first trimester, I think the available data suggests that it's reasonably safe. Now, of course, many pregnant people may not be interested in taking anything. And, in those cases, I might suggest interferon if necessary. One other thing I'll just add to the equation is that, the disease kinetics of patients is different off of treatment. And some people, in my experience, despite starting close to MMR, don't get any higher than like 10-15% at the end of term, and maybe some mild leukocytosis. In contrast, I had a patient who stopped treatment who was close to MMR simply to undergo oocyte stimulation for IVF. And in 6 weeks off of treatment, not only did she lose MMR, but her white count went up to 120,000. That was very shocking, obviously. But, and that's a challenging case because I don't know how I'm going to possibly keep her off of treatment long enough to carry through the first trimester. So in that case, we're talking about surrogates. But I think the ideal scenario, is unfortunately rare, that you're going to find somebody who's in a stable, deep molecular response who can stop treatment and not have to resume treatment. But I do absolutely agree with Jorge that, in most cases, you don't have to really worry unless the white count gets, really high, in which case, if the patient's reluctant to take anything, it's not optimal, but there is also leukapheresis as an option.
So I'm going to give Tina the opportunity to ask the final question here.
I see a lot of different practices in terms of disease monitoring in CML, and some programs that I've listened to have basically said that we are monitoring these patients too frequently, and how, what are the best intervals to monitor these people, and what are you monitoring? Have we moved away from peripheral blood FISH, for example, and are just sticking to the PCR in order to get the best idea of how someone's CML is doing? And so I see varying practices out here. So I think if you could summarize your best practices and your approach to just disease monitoring in stable patients.
That's an awesome question. Jorge?
So what I do is when I start a patient on a treatment frontline or a new treatment, I do it every 3 months. Once my patient is stable on achieves a major molecular response, or around there, and it's stable, I go to every 6 months. I think that's plenty for most patients. If I do a change of TKI, if I change the dose significantly, something like that, I may check again in 3 months to see that I'm not losing or a response or anything like that. But other than that, I don't think you need to stay on every 3 months indefinitely. Once a patient is stable, has a good response, and to me the threshold is MMR. That's every 6 months has worked very well for my practice.